So I have a question. Very often we hear the story of the bench development, obviously when we publish more in basic science journals, jumping, then we see the next thing being a phase 2A trial, for example. There's obviously a lot of disconnect between what you have in the test tube versus putting on human skin and accounting for, obviously, penetration, permeation issues. How does that work into the kind of translational development in terms of figuring out vehicle for, obviously, anatomical location, physiologic conditions?
Yeah, it's not easy. But I think a lot of it, there are different in vitro methods that can be used. There's things like Franz diffusion chambers. There's in vitro things that you can learn about a molecule and try to develop a vehicle that would enhance penetration. They also use other models like cadaver skin, that type of thing. It's very, very challenging in diseases where there's no animal model, like for acne, for example. So you have to do sort of surrogate things. But bottom line is, you do the best you can up front, and then basically the proof is in the pudding if that formulation actually works in patient skin. Yeah.
There have been a couple products that were coming very quickly down the pipeline, I think maybe 2 or 3 that failed in the clinical space. Do you think maybe because there was such a rush and not a focus on, evaluating penetration, evaluating actually 3-dimensional activity versus in cell?
Yeah, that's a good question. I think a lot of that data doesn't get published and we don't see. So it's hard to know with drugs that are in clinical trials that, whether they fail or whether they're successful, unless you have to, it's hard to know exactly what types of studies had been done up until that point. Yeah.
It's fascinating to see that opening slide about the gene chip and the changes in the gene activities. I'm wondering, have you done that with other treatments for acne, like with just doxycycline, or with medications that seem to increase acne, lithium, beta blockers, androgens, to see if you can tease out which of those proteins are involved or enzymes are the meaningful ones?
That's a great question, and that would be. It would be wonderful to be able to do that. In part, we're limited by expense because these types of assays are pretty expensive, but over time, like with anything, prices are coming down. So now the costs associated with whole genome sequencing are getting less and less over time. And there are ways, we've been doing biopsies to do these analysis, but you can also do tape stripping to get enough material to do gene sequencing on that as well. So as the technologies get better, I think there'd be more opportunity to use these types of techniques to answer those questions. Yeah.
With any of the work you're doing, is there any kind of biomarker for why some people don't respond the same way to isotretinoin? A good 70-80%, to your point, will never get acne again, or very minimal, where some, they're going 2-3 courses. Anything come up in terms of the gene array, in terms of the genetic profiling that would make someone more susceptible to having a root?
Yeah, that we don't know that as of yet, but because the studies that we've done are relatively small, and we're collecting the 6-month data, but there's not enough people in those studies to be able to have a cohort that, they responded and they did great forever, or no, they didn't do well for a long time. But over time, I think if we were able to generate more data in large numbers of people, then that would be something to look for, absolutely. And it'd be nice to get to that point because it'd be good to know. Yeah.
Questions?
I just had one. What dose do you like to use for your acne patients? You mentioned the original studies too.
Oh.
I just wonder what you do.
Oh, well, I do something different for every person. Usually, I always, depending on the patient, if there's not a lot of inflammation, I'll usually start them out on 0.5 milligram per kilo. If they have intense inflammation, almost bordering on acne fulminans, I may calm them down with prednisone initially, and then start really low-dose isotretinoin and see how they do, and then maybe gradually increase it if they do better. So for the standard garden variety, I probably start at 0.5 milligram per kilo. And we all know, even at that dose, some patients have a lot of side effects. They have a lot of, chapped lips, dry skin, and you know they're taking their medication. In those cases, I don't feel compelled to make them more miserable than they already are. So I'll keep them on that dose and just treat them for a longer period of time. I think there's also, this I think is fascinating, and I've talked with some colleagues in Singapore and Korea and other places, and I think there's some racial ethnic differences in the side effect profile associated with isotretinoin. And most of these studies, the original work was published in Caucasian patients in the US. And that study I showed you, the old one, was 2 milligrams per kilo. I mean, I can't imagine treating anybody with 2 milligrams per kilo. I mean, I guess it does happen. But in other populations, even at 0.5 milligrams per kilo per day, they have hypertriglyceridemia, a variety of other side effects, and more mucocutaneous type side effects. So I think there's a lot of differences that over time, those of us in clinical practice have kind of picked up on that and adjusted us accordingly. But doing that study or having that data, I think would be great. So I'm trying to get people to put it together. Yeah.
I find that we're often underusing isotretinoin. Either it's a barrier because the pregnancy thing makes it so difficult to either convince the patient or to just logistically. So we end up having, at least I don't know, Dr. Norton, if this is your case, but we have way more males on it than females typically. But, the topical retinoids, they don't work very well, probably mostly due to compliance. So I sort of feel like getting to isotretinoin and getting them clear might be doing a better service to patients in general. So to that end, regarding the products that just reduce sebum, are they going to ever work as well as isotretinoin, which sounds like it has?
I have no idea.
Yeah, exactly.
I have no idea. I mean, and even the products that reduce sebum, those are in cell culture models.
Right.
They haven't been shown to reduce sebum in a patient. So we don't really know.
Right.
Yeah.
But if isotretinoin is so good, then getting to it
I think so, but a lot of that I think is, age and sex dependent too. So if teenagers seem to respond pretty well, and they seem to stay okay many times. But when you get into the adult female, it's a different story. Like, they'll do great while they're on the isotretinoin, and then you stop it 6 months later, boom, they're back to square one. And how many times can you do that? So I think that there's differences there. I mean, if it's the standard teenage type acne that's pretty severe, I agree. And then you observe it more than me, but if someone needs isotretinoin at 13 or 14, they're probably going to need it again when they're 17. So in that window of time over which they have acne, if their acne is occurring really young, I think that oftentimes they do need retreatment. My perfect favorite patient is the 17-year-old male who is just starting his senior year in high school, and it's like, okay, this is your time. So that's just perfect in every way. So that's the ideal situation. Yeah. Mm-hmm.
It was interesting on your studies, you talked about the kids who did not have acne as the normals, and the global burden of disease would say they are abnormal.
Oh, yeah. No, you're right.
So there may be something different about those people there may be something unique about people who never get acne that deserves attention because they are the adult.
Oh, true. That is true. But these weren't people that, you're absolutely right. That would be really good to know. These were not people that never had acne. These were people who didn't have acne at the time they did the study. So there's no clear distinction for the phenotype in terms of never having had acne. They may have had acne at one point or another. Yeah, but no, you're right. Mm-hmm.
So you were asked about how you treat. What about monitoring? Because actually a lot of the new data that's been coming out of Penn State about appropriate use of labs and monitoring patients that maybe things have been a little overzealous. What are your thoughts on that?
Yeah, there's a lot of differences in how people monitor for isotretinoin. And since, I guess, has anybody thought that there's a good reason to have iSplash? But I'll give you one. You have a database. So for in our practice, we have, it's a pretty large practice. We have 20-something faculty and 12 residents. And so all of our patients we cross-cover, so they're all in our iPledge system. So we have a way to find out who these people are. And then, we've contacted them and, done studies and such. And we've been able to do these retrospective reviews by pulling their chart and looking at these things. And so with the lab monitor, we've done a couple studies to show, and other people have done a similar thing, is that the majority of side effects related to triglycerides or lipid metabolism generally occur within the first 2 months of treatment. So things that the standard to check would be, CBC, lipid liver, pregnancy, that sort of thing. The changes in CBC are very rare. It's not to say that they don't happen, but they're not common. And most of the changes in lipids tend to occur in the first 2 months or so. So we examined a lot of cases and tried to put this data together. Other folks did a similar thing. So we adopted a new sort of guideline for our practice that we test at baseline pregnancy, liver, lipid, and then we check it again after 2 months of treatment. Or if we're still in the dose escalation phase, we might check it at 2 months and then check it again if their dose is getting escalated. And
Any questions?
Do you consider a cumulative dose? Like many years ago, we used to think it was a cumulative dose over the 5 or 6 month.
Yeah, there's a lot.
And if you're starting lower doses, should you treat them longer? And then ultimately, they tolerate higher doses later.
Right.
As you go.
Right. That's a great question. I think the jury is out on that one. There's many of you are familiar with it, but the folks in Europe tend to dose to a cumulative dose of 120 to 150 milligrams per kilo. That's for sort of standard acne. When you have a lot of truncal acne, oftentimes you need to have a higher cumulative dose. So that's sort of a guideline. But if Jerry Tan wrote a paper looking back at how that guideline was developed, where did it come from? It basically came from a study in the UK that my friend Alison Layton was involved in. And they did a retrospective review looking at the rate of remission in terms of what those patients' cumulative dose was. And they looked at the data and they said, well, if it was in this range of 120 to 150 for the most part, these people had substantial length of remission. So that's where the number came from. It wasn't prospective, it was just sort of a retrospective analysis of their large data set at Leeds. But I tend to practice that way. I tend to go for the cumulative dose, a higher dose with truncal acne, just because I think that works a little bit better.